Sometimes people confuse that paracetamol is an anti-inflammatory drug, but it is not. Paracetamol claim and still a belief that paracetamol causes nephrotoxicity or is bad for the stomach, etc. So this is something that we have to dispel in our patients, and it does take some effort from our side to tell them no, paracetamol has no such toxicities. So paracetamol has no nephrotoxicity, NSAIDs are significantly nephrotoxic. Patients don't know that paracetamol is no better than placebo. So they would probably feel good about few interactions of paracetamol. Probably the only one that I know is paracetamol with warfarin. Warfarin users cannot take more than 2 grams per day of paracetamol because the warfarin levels increase.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Paracetamol is probably the most commonly prescribed allopathic drug the world over. And whatever pathy you practice, I'm sure you use paracetamol. But there are some things about paracetamol that we are not familiar with, and today's talk will be about those things. Absolutely related to day to day medical practice, not about complex pharmacology, etc. Let's jump into the topic right away. So, here, sometimes people confuse that paracetamol is an anti inflammatory drug, but it is not. Paracetamol is not like NSAIDs in the sense that it is not anti-inflammatory. Paracetamol is analgesic, not as strong an analgesic as NSAIDs or opioids, but a very useful analgesic, a pain medicine. And paracetamol is an antipyretic, a fever medicine. Again, not as strong as some NSAIDs as fever medicines, but a very useful one because of the significant paucity or lack of side effects. So let us discuss the comparison between NSAIDs and paracetamol with respect to adverse drug reactions. There is amongst laymen still a belief that paracetamol causes nephrotoxicity or is bad for the stomach, etc. So this is something that we have to dispel in our patients, and it does take some effort from our side to tell them no, paracetamol has no such toxicities. So paracetamol has no nephrotoxicity, NSAIDs are significantly nephrotoxic. Paracetamol has no GI side toxicity. NSAIDs can cause peptic erosions and ulcers. Paracetamol has dose-related hepatotoxicity. NSAIDs can cause idiosyncratic hepatotoxicity. As you know, nimesulide is a notorious hepatotoxic NSAID. Paracetamol, you need to take 10 grams, maybe 15 grams to really damage your liver. So, in that sense, it is a predictable dose-related toxicity, whereas NSAIDs can cause completely unpredictable single-dose toxicity too. Skin rash is very, very rare, much rarer with paracetamol than with NSAIDs. Having said that, paracetamol has been documented to cause even the Steven Johnson syndrome, but it is extremely rare, much, much rarer than NSAIDs. And paracetamol does not aggravate asthma or respiratory disease. As you know, there is a condition called AERD, aspirin exacerbated respiratory disorder. Aspirin and some NSAIDs, especially the non-specific NSAIDs, can aggravate asthma. Paracetamol does no such thing. Paracetamol has no cardiovascular toxicity. NSAIDs can worsen hypertension, heart failure, coronary ischemia, but paracetamol, nothing. So let's come to the maximum doses of paracetamol. This is an area where we have to take a little more care than we usually take, and a little more liberties than we usually take. The first liberty is this, that the maximum dose of paracetamol that can be prescribed by a physician in someone younger than 75 is 4 grams per day. We should not hesitate to give 4 grams per day. We had a lot of chikungunya this year, and Chikungunya is a classic example of using the maximum dose of paracetamol. I would give it 500 milligrams 4 hourly, or even more frequent, 8 tablets of 5 milligrams, 500 milligrams per day. I would use for several days. How long can you use 4 grams per day? In some people, say for example, in people with fibromyalgia who do get relief with paracetamol sometimes, I would use it lifelong. Maybe not 4 grams per day, but at least several tablets per day for life should be very, very safe. If you take it per kg body weight, then 60 mg per kg per day would be the maximum supervised dose of paracetamol. And the maximum unsupervised, meaning how much can a patient take without asking the physician? It would be 3 grams per day. You don't need to ask me, unless you're an alcoholic, cirrhotic, etc. You don't need to ask me how much paracetamol per day can I take. Mg per kg would be 45 mg per kg. 3 grams per day, 6 tablets of 500 milligrams are absolutely safe to take. The maximum dose in an alcoholic changes. Chronic alcohol consumer cannot take more than 2 grams per day. Uh, I'm talking about an alcohol consumer who doesn't have significant liver disease. A patient who's on warfarin, this is one of the few interactions of paracetamol, probably the only one that I know, is paracetamol with warfarin. Warfarin users cannot take more than 2 grams per day of paracetamol because the warfarin levels increase. The maximum dose in a compensated cirrhotic, compensated chronic liver disease, alcoholic or not, is 2 grams per day. Whereas if there is decompensated liver disease with, say, enzyme elevation, ascites, histoencephalopathy, etc., you would not give paracetamol at all. The maximum dose in those very old, maybe above 75 or so above 85, very frail, less than 50 kg body weight, 2 grams per day. So I'll repeat, below 75, otherwise healthy, 4 grams, 75 plus 3 grams maximum, but probably 2 grams, especially if they are very old and frail. In patients who are on INH inflammation, this is important because many of our tuberculosis patients do get fever, maybe get body ache, maybe get joint pains due to tuberculosis reactive arthritis, or pyrazinamide. Then these patients should not be given more than 2 grams per day because of a liver related drug interaction where the toxic metabolite of paracetamol levels rise. Therefore, personal poisoning becomes a little more easy. So similarly, if you are on older anti-epileptics like phenytoin, phenobarbital, carbamazepine, the maximum dose should remain 2 grams per day. Amongst these older anti-epileptics, we currently mainly, I think, in at least urban India, we use carbamazepine, say for trigeminal neuralgia. So in these patients, you have to take care not to give more than 2 grams per day. Let us talk about some oral paracetamol formulations. There are immediate release formulations and then there are extended release formulations. The immediate release formulations, like simple kerosene advance or dolocalpol, uh, we have a duration of action of 4 hours. Now, is this duration of action for 500 milligram also, 650 also, and now there are some 1000 milligrams immediate release tablets? I would think so. 4 hours is the usual duration of action of all immediate release preparations. Whereas the extended release preparations have an action of 8 hours. Let me talk about these preparations also again. Some I don't know any extended release preparation that is purely extended release, meaning usually they are combinations of immediate release and extended release. So, for example, a brand called Lanol ER, 650 milligrams, contains 325 milligrams of immediate release and 325 milligrams of extended release in one tablet. So, the logic of this, of course, is to give quick relief uh, and within 30 minutes, say, and then give some longer relief for 8 hours with some of the dose. Paracetamol formulations also include suppositories. Suppositories, one brand is Neomol, would be especially useful in pediatrics and in the very old who cannot swallow tablets, cannot take syrups because of some reason, maybe dysphagia, say Parkinson patients, etc. In these patients, you may give paracetamol suppositories which are available from 80 milligram onward in multiple strengths. And then there are paracetamol parenteral formulations. These are interesting. There is a brand of paracetamol called Febrinil. There must be many brands. I'm just taking one example. Febrinil is a brand that can be used both intramuscular and intravenous. It's a 3 ml ampule. Used to be available in 2 ml also. Maybe it's still available in 2 ml too. But 3 ml ampules are available here where I stay. And each ml contains 150 milligrams of paracetamol. 3 ml ampule can be given either intramuscular or intravenous. This has an interesting use, which I'll come to later. And then there is this injection brand called Acnil, which is a 3 ml ampule, but intramuscular use only. I think Acnil is, at least on online pharmacies, is not available significantly. And I think it is dying a natural death because once we have an intravenous formulation, which can also be given intramuscular, why do we need a purely intramuscular formulation? Then there is this intravenous preparation of 100 ml vials, uh, brand name Pacimol, Pidimol, etc. 1000 milligrams in 100 ml, only for, of course, intravenous use. These are commonly used perioperatively. The tragedy about this paracetamol formulation is that though um, to the dealer the cost is about 25-30 rupees per vial, MRP still remains at 400 rupees or even more in most cases. Now, this is ridiculous. I don't know why there has been no price cap on intravenous paracetamol of this kind, but we can do a thing that can make this cheaper, and this is we'll come to later just now. So here are some practical tips. In fever, don't use Lenol ER. You have to use an immediate release preparation. So, and between 500, 615,000 in fever, if you're using an immediate release, use maybe 500 or 650 rather than 1,000. So that uh, duration of action of 4 hours, 500 milligrams is often enough to suppress the fever. Occasionally, you will need 1,000 milligrams, and especially if the patient has severe fever with severe body ache, then you can use 1,000 milligrams. In chronic pains, you may use immediate plus extended release preparations. Say pain of osteoarthritis. We know that osteoarthritis does not. There is no recommendation for paracetamol now anymore, but I still feel it's a useful drug to use as a, even if you think as a placebo. In fever, you can give an as required basis, an SOS or a PRN basis. In cancer, you have to give it by the clock. In the first 2 or 3 days of dengue, or in chikungunya, the fever is high grade, I do insist on round the clock dosing so that the fever does not crash multiple times from its peaks, because crashing fever can give rise to a lot of sweating, a lot of diaphoresis, and therefore some dehydration. So I like to maintain regular paracetamol during periods of high fever, especially in continuous fevers like early chikungunya, dengue, and maybe enteric fever. In cancer, we like to give pain relief by the clock. Of course, paracetamol is the first step of the ladder of cancer, and you should give it maybe 4 hourly, 6 hourly paracetamol. Uh, Not getting too worried about the maximum dose in some situations because of the shortened lifespan of many terminally ill patients. 100 ml intravenous paracetamol, which I said is often 400 milligrams or more, can be substituted easily by adding 2 ampules of, say, the brand called Febrinil to 100 ml of normal saline. So, if you want to give it, say, as a palliative drug at home or in your clinic sometimes, 100 ml bottle of normal saline are available very cheap in 450 milligrams, so 6 ml contains 900 milligrams of paracetamol, and that should be a good substitute for your very expensive 1000 milligrams of IV paracetamol. You are basically cutting the cost by more than 75%. Here, one tip in osteoarthritis, I was saying, in osteoarthritis of the knee, for example, even though paracetamol is considered no better than a placebo, I would use it as the cheapest available placebo with good efficacy. The good thing about paracetamol is that most people know that it should give pain relief. Right? Osteoarthritis patients don't know that paracetamol is no better than placebo. So they would probably feel good about taking paracetamol. And there are so many patients who say that one paracetamol before going uh, out of the home with osteoarthritis gives them significant relief. Now, this is very commonly heard. So, even though evidence says that paracetamol is so-called useless in OA, I would still say use it. Use it where the patient feels better. And now let us go to some paracetamol combination. Very interesting combination. Very illogical sometimes, and sometimes very useful. So here are some migraine combinations. You know that migraine headaches come with nausea, and therefore sometimes we have paracetamol with nausea medicines together. Uh, Domperidone with paracetamol, one brand name is Cetadom, has only 325 milligrams of paracetamol with 10 milligrams of domperidone, and Metopar, which is a brand of paracetamol with metoclopramide, that is Perinom, has instead of 10 milligrams of Perinom, 5 milligrams of Perinom and 500 milligrams of paracetamol. Now, why do we use these combinations? Uh, in a patient with migraine, their compliance is not worsened by giving two separate medicines. You can easily give paracetamol, whatever strength you like, with Perinom, whatever strength you like. But but these these medicines have become popular, and I fail to see the logic. Why should we give 325 milligrams of paracetamol or 5 milligrams of uh, metoclopramide in a patient with severe migraine? Then there are these combinations ergot. You heard of vasograin. There used to be something called migranil in the past. Now we have migranil EC, which is different. But vasograin contains four drugs: 250 milligrams of paracetamol, 100 milligram caffeine, ergotamine 1 milligram, and stemetil or prochlorperazine 2.5 milligram. If you see this combination, you know that paracetamol is underdosed, prochlorperazine is underdosed, maybe caffeine or ergotamine strengths are correct. So what do we do with this formulation? Patients will take vasopressin, they are taking underdose. So shall we try to add a drug to these? Let us see. I'll give you a couple of combinations. So now tell me which is better, vasograin alone or vasograin which has 250 paracetamol. Add 650 paracetamol to that as another tablet, and then add another half tablet of stemetil to make the stemetil dose 5 milligram. Is this a good combination, or can we give migranil EC with paracetamol plus Stemetil? Uh, Migranil EC, you might remember, is a brand that contains ergot 1 milligram and caffeine 100 milligrams. No paracetamol in migranil EC. So you can give paracetamol plus Stemetil plus migranil. So, what do you do with these combinations? And if you have a habit of writing these combinations, prescribing them, how can we correctly prescribe the strength of each constituent by adding a medicine is something that we'll have to think about. And then there are passive combinations and NSAIDs. These seem to be the most illogical combinations. Uh, you have heard of Combiflam or Ibugesic Plus. What is 325 milligram of paracetamol doing with 400 milligrams of ibuprofen in a TDS formulation? You give Combiflam 3 times a day and you're underdosing paracetamol significantly. So, is paracetamol adding anything to the ibuprofen? I don't think so. Ibuprofen is good analgesic, a good antipyretic, a good anti-inflammatory. Paracetamol in these doses, neither of these. So, I think we can avoid Combiflam. I have this habit of writing Combiflam. I have Combiflam in my house, but every time I take Combiflam, I will probably add a small tablet of paracetamol to the Combiflam so that the paracetamol dose is logical, or I will take ibuprofen alone separately. So my prescription has increasingly become ibuprofen alone, or ibupara with an extra paracetamol, uh, to make it more logical. You feel good when you're logical. You should not continue to be illogical all your life. And then there is this formulation of 100 milligram aceclofenac with 325 milligram of paracetamol. Very commonly, Acinec P, for example. A completely illogical combination, because this is once aceclofenac is twice a day dosing. 325 milligram paracetamol twice a day has no utility. You might as well give plain aceclofenac, and that will save cost. But aceclofenac, per se, I'm using this brand because it is BD dosing, and so that's an illogical dosing. I hate aceclofenac, but I'm just saying that these combinations you should know the constituents of, and then prescribe, instead of blindly following what you come across in medical literature. And then there are these paracetamol combinations with muscle relaxants. Again, see the variety of uh, logic defying combinations. Some have paracetamol 500 milligrams. For example, Myori Plus or Zyka MR have paracetamol with thiocalcicoside, but paracetamol is a decent 500 milligrams. And then some have 325 milligram paracetamol, like Myospas. Again, it is methocarbamol. No, sorry, I'm sorry. Myospas is chlorzoxazone with paracetamol, where the chlorzoxazone is the correct dosing of 500 milligrams and paracetamol is 325. So one of my favorite prescribed drugs is Myospas for muscle spasm, etc. But then when I give Myospas, I always add a paracetamol 500 milligram 3 times a day to Myospas to make the dose of paracetamol at least 2700 milligram per day. So Myospas TDS, paracetamol TDS is one of my favorite prescriptions. And then there are some combinations with muscle relaxant that have just 250 milligrams of paracetamol, like Robinexol, which has methocarbamol with paracetamol. So our job is to read the constituents of each combination that we give in any symptomatic drug, even cough syrups, for example, so that we don't make stupid mistakes, and we don't. When I realize that I've been making a mistake for so many years or decades of my life, I feel like hanging my head down in shame. So let's be correct in our pharmacotherapy. And then there are paracetamol combinations for URTI. As you know, many drugs contain paracetamol with phenylephrine, with CPM or similar antihistamine. Uh, phenylephrine has come under a cloud. One, phenylephrine causes a lot of congestion to be blocked inside. Now, patient feels choked. The cough gets stuck here. That's the common side effect. And now phenylephrine has been said to be useless by the US FDA in the recent news. So even though I have used a lot of Sinarest and Vicoril, etc., I think it is time for us to go away from phenylephrine and give mucolytic separately or antihistamine, like Dex. I use polaramine, that is Dex CPM, dexchlorpheniramine maleate, as an antihistamine, and give paracetamol separately if you can. So I would use, in a URTI situation, I would use paracetamol with Dex CPM, and if necessary, slight mucolytic drug. So this is or a cough suppressant even, depending on what the symptoms are. So these URTI combinations are fairly illogical. Even the syrups that you will see are fairly illogical combinations. And yeah, then there are paracetamol combinations with opioids. How do you use Ultracet and Ultracet Semi? As you know, Ultracet has 325 milligrams paracetamol, and Ultracet Semi has half that, 162.5 milligrams of paracetamol. Now, this seems to be a ludicrous dose, and yet Ultracet and Ultracet Semi are very popular, and I use them. I use them because I use them under the guidance of start low, go slow. Meaning, if there is a patient who requires an opioid and the patient has to, is an elderly patient, for example, or even anybody else, where because opioids have to be started low, I will sometimes use something like Ultracet Semi, which has a very small dose, half of 37.5. I can't do the math, but half of 37.5 milligrams is the tramadol dose in Ultracet Semi. That I will give 1 3 times a day, and maybe then, if tolerated, I will go to Ultracet, and if tolerated, I will go to plain tramadol. Tramadol is available as a 50 milligram capsule. So I will go to tramadol from the Ultracet Semi stage through Ultracet to plain tramadol, fully realizing that the first and the second step, that is the step containing Ultracet Semi and Ultracet, have a useless quantity of paracetamol. But unfortunately, tramadol is not available in a strength lower than 50 milligrams by itself. So I have to kind of go through the combination to reach a slightly uh, optimal dose. Yeah. So short lecture, I'm sure. Uh, there are many questions. There are some areas that I've left behind. I'm sure I'll be able to cover them in the Q&A. It's an interesting topic because it's used so frequently, the drug. We can take the question, Dr. Barsha.
Thank you, sir, for that wonderful presentation. We do have some questions coming in from our doctors. We are beginning with the Q&A. So I'm going to be taking one of the earlier questions that we had. It was from Dr. Kulkarni, who was asking, please enlighten about paracetamol toxicity and its management.
Yeah, paracetamol toxicity, of course, as we know, occurs uh, in adults at doses as low as 10 grams. 10 grams taken together in a very short space of time. And the toxicity reveals itself in the form of hepatotoxicity after a few, maybe 48 hours or 72 hours of paracetamol injection. The management is with N-acetylcysteine given intravenously, not an area where I'm an expert. The patient is, of course, any patient who comes to you with an overdose of paracetamol, usually intentional, right? It is almost never accidental. Then you would want to admit the patient. Don't wait for hepatotoxic to appear. You must admit as soon as you come to know that the patient has overdosed themselves on on paracetamol. Yeah. Thank you, Dr. Kulkarni.
Right. So the next question is from Dr. Yadav. If patients can use paracetamol in cholangiocarcinoma.
Uh, I suppose you are talking about the liver toxicity of paracetamol if it increases in cholangiocarcinoma. If the enzymes are decent, I cannot specifically answer that very well, but if the enzymes are decent, there is no obstructive jaundice due to cholangiocarcinoma. I don't see any reason why you cannot use paracetamol. The problem with liver disease and paracetamol is that if a patient of liver disease has significant fever, uh, then what do you give is the problem. You should not give NSAIDs, you should not give paracetamol. So we have very limited choice in managing fever in patients with decompensated liver disease. But yes, in this situation, I think I would use paracetamol if the enzymes are normal.
Right. So now, next question from Dr. Mishra, antipyretic of choice in decompensated cirrhosis of liver.
Decompensated cirrhosis of liver, antipyretic is a big problem. As I said, we just said what probably is the safest is a steroid dose. If the patient has very high fever and you have to suppress the fever, an intravenous steroid dose would help. Remember, opioids do not help fever; they can help pain. Remember, NSAIDs are a problem with liver disease, and remember, paracetamol is a problem. So between paracetamol and NSAIDs, I would choose an NSAID. And if it is for a short term, I would probably use steroids.
So the next question is from Dr. Asif. What about paracetamol on post-op LSCS?
Post-op cesarean section, I don't know whether there is any contraindication to paracetamol. Any particular reason why you're asking this? Because I'm sure you have a pointed reason for asking about LSCS. But I don't see any contraindication. You can use intravenous or oral paracetamol. Whether it will be very useful because you're looking at an Inflammatory condition also probably, where the pain is also due to inflammation, and therefore you may not be able to use effectively paracetamol for the pain. But yes, I would use absolutely freely.
So next question is from Dr. Gupta. If patient's fever level is if patient fever is high grade, even after paracetamol injection, it's not getting low, can we use steroid dexamethasone for a while?
So one thing that is important is, we unless there is hyperpyrexia, where 106 degrees, or some CNS involvement, delirium due to the fever, etc., we should not be scared of fever. Fever is a in many ways, fever is a protective response of the body. So if there's 104, 103 fever, and the patient not terribly uncomfortable, then we may not use steroids, because depending on the cause of fever, steroids can aggravate the cause. The etiology can be aggravated by steroids. So I would use an NSAID if there is no contraindication to the NSAID over steroids. NSAID I would use unless there is a low EGFR, unless there is acid peptic disease, unless there is ischemic cardiomyopathy, unless there is uncontrolled hypertension, which are all contraindications to NSAIDs. I would use NSAIDs over steroids. Thank you.
So another question from Dr. Gupta was, can we start PCM infusion in extreme conditions, and what is the infusion rate per hour in a normal person?
Which conditions did you say? In
Extreme conditions.
you can use infusion. Infusions are safe if you are giving intravenous, even in your office, even in your clinic. Infusions are safe. Anaphylaxis to paracetamol is, at least not that I have heard of any case. But if you are using an infusion, remember the one side effect of intravenous infusion paracetamol is hypotension. You can rarely cause a slightly low BP, not as a part of anaphylaxis, but a slightly low BP, and therefore the patient's baseline blood pressure is low because of say dehydration. You might be careful and you might be slow in the infusion. Otherwise, a 100 ml infusion should be given. I would give it over 1 hour. Yeah.
So next question from Dr. Kulkarni. What are the side effects of paracetamol suppositories?
So, what are the side effects of paracetamol?
I think some in suppositories.
So rectal paracetamol, that is anal suppositories of paracetamol, side effects. I don't know. I don't know any particular side effect of rectal, but maybe you know something that I don't know. Uh, I don't think there are erosions or local irritation due to paracetamol in the anus. Yeah.
So next question from Dr. Reddy. Best antipyretic and analgesic in CLD and CKD patients. Please guide.
In CKD patient, NSAIDs are contraindicated. Best analgesic for me would be paracetamol. Best antipyretic would be paracetamol. And the other level of safe and analgesic would be opioids. In kidney disease, opioids are okay, paracetamol okay. There is no dose adjustment in kidney disease of paracetamol or opioids. NSAIDs are a complete no-no in CKD. Uh, Steroids are, of course, allowed in CKD. They don't worsen CKD. They may worsen the blood pressure in which these patients have. They may worsen the fluid overload a little bit these patients have. So you can use steroids in CKD, and you have to, of course, give a short duration of steroids. Yeah. And in CLD, we just discussed CLD. CLD, if compensated, I could use paracetamol up to 2 grams per day. Decompensated CKD, CLD, I would not use paracetamol at all.
So Dr. Jitendra asks, paracetamol in viral hepatitis for fever. What are the precautions?
Again, the precautions are because viral hepatitis has high enzyme elevation. I would probably avoid paracetamol as much as possible. And if I do use it, I would use it in small doses. Uh, I I probably, if viral hepatitis can have enzymes of 1500, 2000, 2500, etc. So I would be very wary of. So I would use tepid sponging. I would tolerate the fever, because the fever, as I said before, is not a big issue here. It's not a problem. And those conservative measures of tepid sponging the patient, for example, should do well.
Right. So the next question is from Dr. Singh. What is the PCM dose for periop, analgesia, and deranged LFT?
Deranged LFT, I would like to not use paracetamol at all. Uh, so we have a problem there. Uh, Opioids is what I would use for analgesia in deranged LFT.
Right. So the next question from Dr. Arun. In DCLD patients, which drug can be used instead of paracetamol?
In CLD patients, again, as I said, opioids are relatively safe, so I would use opioids. And if you are using opioids, remember, I would use tapentadol more than tramadol if oral opioids are allowed, because tramadol has some liver-related drug interactions, and also mainly tramadol has liver-related uh, genetic polymorphism, meaning different efficacy in different people. So yeah, tapentadol I would use. Of course, you can use in steroids if there is no other contraindication to steroids, but I would not use paracetamol if decompensated.
So next question from Dr. Sunil. Is there any cumulative paracetamol toxic dose taken over a period of time? N-acetylcysteine dose and toxicity, please.
I don't know the NSAID dose because it's a matter of probably intensive care unit specialty, so I don't manage that very well, very significantly. Uh, about what was the first part of the cumulative dose? Now, that's an interesting question. If I were to take 4 grams every day for 10 days, which is 40 grams, would that become a cumulative dose? No. Paracetamol is rapidly excreted. So, even if you take 4 grams per day for months in patients otherwise healthy, good liver, then there's no problem. So, in many chronic pains, you would give paracetamol in a good dose for several days. So, there is no cumulative toxicity, like we have in hydroxychloroquine or chloroquine. There's a cumulative toxicity. In paracetamol, I hope there is none.
So next question is from Dr. Patel. Paracetamol in low count in platelets, what are the precautions?
So, luckily, paracetamol in thrombocytopenia is absolutely safe. NSAIDs are a problem, especially aspirin is a problem, as you know. Uh, NSAIDs I would not give below 50,000 platelet count, but paracetamol I would give up to whatever platelet count does not matter. Yeah,
So we do have a lot of questions coming in from our doctors. Is it okay if we take a few more?
it's just 940. Sure.
Hmm. So the next question is from Dr. Ahmed. What about combining diclofenac, aceclofenac with paracetamol?
I just spoke about it before. So the combinations that are available are illogical because they contain a small quantity of paracetamol. As per drugs, as I said, amongst NSAIDs, aceclofenac, diclofenac are far more toxic to the heart than naproxen. So if I have to use an NSAID, I would use naproxen instead of aceclofenac. And naproxen paracetamol combinations I don't think are available, at least in the regular branded lines. Uh, and as I said before, aceclofenac 100 milligrams is combined with 325 paracetamol, and aceclofenac dose is 100 BD, and paracetamol 325 BD is no dose at all. So that combination I think is fairly illogical.
Next question from Dr. Reddy. Can mefenamic acid be given in DCLD patients?
Decompensated liver disease, all NSAID should be a problem. I don't know whether mefenamic acid is any better than others. I do know that amongst the NSAIDs, the most hepatotoxic would be nimesulide. So I don't think I would use mefenamic acid if the decompensated disease.
Next question from Dr. Rahman. Antipyretic in the case of severe dengue hepatitis with thrombocytopenia.
Antipyretic severe dengue with dengue hepatitis. Very interesting situation that you've created, Dr. Revan, and you have put us in a fix, right? The patient is in a fix because of very high enzyme elevation, paracetamol would be avoided. and therefore antipyretic. I would use just conservative measures like cold sponging and no steroids in this situation, definitely, because dengue mortality can be increased by steroids. No NSAIDs in this situation, again because of the low platelet count, and no paracetamol. But luckily in dengue, by the time these complications occur, fever is already declining. So that is one good thing that happens in dengue. The peak fever is at the first 2 3 days. The complications are after 4 5 days. So we may not be put in such a fix.
Next question from Dr. Vidya. Are there any contradictions for users of paracetamol in J6PD deficiency?
No, none at all. None at all. Paracetamol is absolutely safe in very severely G6PD deficient patients also. So I don't think we should be worried.
Dr. Anand asks, what about paracetamol used for fatty liver and NASH?
Fatty liver and NASH with mild enzyme elevations should not be a contraindication to paracetamol. They are not decompensated liver diseases. And as I said, if enzyme elevation is there with NASH, then maybe 2000 milligrams would be your maximum paracetamol dose per day. But otherwise, uh, no, no problem at all.
Dr. Madhav asks, do you advocate paracetamol following vaccination?
That's an interesting question again. There are two areas where I like to give what you could call a prophylactic paracetamol. Vaccination, yes, especially the Shingrix vaccine that we have. I would like to give paracetamol on the day of the vaccination, before the vaccine is taken, and thereafter. In fact, in Shingrix, I would not mind in a young patient, even ibuprofen was given because the local inflammation can be significant. The other situation where paracetamol can be given beforehand, something that I just thought of in terms of vaccination. I'll think about this. That is in if you give bisphosphonates. If you're giving intravenous zoledronic acid, bisphosphonate, which is given once a year, as you know, for osteoporosis, those patients who are on who take bisphosphonate, zoledronic acid intravenous, get a lot of fever and body ache on the first day. And in these patients, on the day of zoledronic acid, I tell them to come with the paracetamol taken already, and then continue the paracetamol 2 or 3 times a day, even though they don't yet have developed body ache. So it's kind of a prophylactic paracetamol that I like to give to make them comfortable.
So Dr. Jitendra asks, dose of tapentadol and its adverse effects and contradiction.
Tapentadol, like tramadol, is an opioid, an oral opioid. Tapentadol is also available as a nasal spray. Tapentadol, 50 milligrams BD is a typical dose of tapentadol. Maximum dose is 200 milligrams per day. You have to start low, go slow, as with any opioid, and it's a it's a habituating drug, of course, like any opioid. The side effects are those of opioids. The principal side effect is constipation. You must, whenever you prescribe an opioid, the number one rule is co-prescribe laxatives, meaning laxatives have to be given prophylactically. You don't have to wait for constipation to occur. All patients receiving opioids must take laxatives. So that is one rule that we should follow. Other side effects, of course, that you know are nausea, uh, slight dizziness, and of course, drowsiness can occur, vomiting can occur. Yeah, so they are regular opioid side effects. Uh, and I like tapentadol more than I like tramadol. Unfortunately, tapentadol is not available in smaller doses than 50 milligram, but fortunately, it's a tablet preparation and not a capsule preparation like plain tramadol. So, yeah.
So the next question from Dr. Suhail, paracetamol plus mefenamic acid as an antipyretic in pediatrics, your comments.
The most popular antibiotic in pediatrics as an NSAID after paracetamol is mefenamic acid. So, my comments are mefenamic acid is used by so many pediatricians that it would be incorrect to say that it's not a good drug. It's probably a good drug. I don't know why ibuprofen is not preferred over mefenamic acid, uh, but if you wish to use mefenamic acid, so be it. Another area where mefenamic acid is very popular, of course, is dysmenorrhea. These two areas make mefenamic acid survive. Without these two areas, mefenamic acid would have been relegated, like we have relegated meloxicam or almost relegated peroxicam. So yeah, but it is a drug that can be substituted. Uh, yeah.
So Dr. Patil asks, paracetamol use in GARD.
Paracetamol is safe in GRD. Most important thing is paracetamol does not cause any worsening of pre-existing ulcers or acid reflux, and therefore is one of the best analgesics and antipyretics to give in patients with pre-existing GRD. Also, uh, many patients, elderly patients who have GRD, are on aspirin. In these patients, uh, paracetamol is the safest analgesic to give because NSAIDs with aspirin will cause a problem. So any patient on aspirin, you have to be careful about NSAIDs. But with paracetamol, there is no problem with giving with low dose aspirin. Yeah.
Another question from Dr. Patil was how to manage with the side effects, and we have quite some questions regarding the side effects of paracetamol. So,
So this, other than the overdose, the management of which I'm not an expert at, other than the overdose of paracetamol, which is called paracetamol poisoning, the side effects of paracetamol are usually nocebo effects. I don't think there are any real side effects of paracetamol, except, of course, a rare situation where allergy occurs, allergic rash can occur. Uh, Nocebo effect basically is where the patient expects a side effect, has heard that paracetamol can cause a problem and gets a problem. That's a nocebo effect. Uh, there are paracetamol formulations which cause rash, but when you change the formulation, the rash does not occur with the next formulation. That must be something to do with the excipients added to the paracetamol uh, preparation. So, if your patient does get a rash with paracetamol, say a brand like Calpol, for example, then do try another brand like Medicine or Crocin, so that you are sure that paracetamol is, uh, in general, intolerant, not tolerated. Yeah.
so Doctor, staying in the last two questions for tonight. Next is from Dr. Vidya. Paracetamol use in ischemic colitis. What are your comments, sir?
Ischemic colitis as a contraindication to paracetamol use, I don't think so. I hope you're asking whether it's a contraindication. Any GI ulceration, erosion, ischemia is not a contraindication. Any diverticulitis or appendicitis or any such disease should not be a contraindication to paracetamol at all.
So, last question from Dr. Madhav. What is the ideal antioxidant to prevent drug-induced hepatitis?
Yeah. So I'm quite sure that there is no such drug-induced hepatitis. Antioxidants for, I would love to ask this question to you, but if you have any knowledge about this, because I have zero knowledge about antioxidants as preventives for drug-induced hepatitis. But there might be, and you might be right in asking this question.
Thank you.
Thank you.
All our questions.
All our questions.
Um,
Pleasure, pleasure, pleasure.
there has been a lot
There has been
from our doctors.
from our doctors
Thank you for this session.
for this session
See you soon on
also
Netflix.
on Netflix.
Thank you, sir.